Today there are really four major surgical procedures that are accepted in our program. The adjustable gastric band, the sleeve gastrectomy, the gastric bypass, and the laparoscopic duodenal switch. The adjustable gastric band is a device-driven procedure. It is the safest procedure that I have. And what we do is laparoscopically place a silastic or plastic device around the stomach. This device is attached to an access port that we place under the skin that allows us to add fluid to the device to slowly adjust the amount of restriction that a patient has. So these patients and I will work with their band on a monthly basis to have their device and their diet adjust so that they can gradually, slowly lose weight. When this band is around the stomach, it allows us to create a small portion of stomach above the band that acts as a small reservoir. I call it a speed bump. It slows foods entering into the stomach, and this allows us to control the amount of food that they're able to eat at one time. Most patients with the lap band are able to lose about half of their excess body weight. I do have to see them in the office every 4 to 6 weeks. It is really a follow-up driven operation. But with the right patient, this can be an effective operation.
The gastric sleeve is also done laparoscopically. The idea is we're going to put small incisions throughout the abdomen where we can manipulate the stomach and make it smaller. The way we do this is we approach the stomach and use a stapling device to cut along what we call the greater curvature, the longer side of the stomach. That turns the stomach from a football shape into more of a banana shape, almost like the sleeve of a long sleeve shirt. By doing that, we do two major things. One, we make the stomach a smaller reservoir for food so that patients do feel full sooner, just like the band. But by taking this portion of the stomach out, we do impact the majority of those gut hormones. Gut hormones that tell you that you're full normally are low in large patients. The ones that tell you you're hungry tend to be up. That process seems to reverse for about 6 months to 18 months after surgery. Studies seem to show that impacts greatly the amount of weight loss that can be expected because of that. The sleeve does not reroute the bowels in any way, but it does remove part of the stomach. We find this is a good option for patients who are looking for rapid weight loss, and particularly patients who have diabetes but are a little bit nervous about the Roux-en-Y gastric bypass. The sleeve gastrectomy is an option for all patients who qualify for surgery, but particularly larger patients who have a BMI of greater than 35, 40, 45, even 50, it's a viable option for them. We use something called excess weight loss, which is the amount of, the excess weight is the amount of weight you have to lose. So if you take the weight you are when you meet the surgeon minus that BMI of 25 weight, which would be the normal weight, that's your excess weight. We expect a sleeve patient to lose about 60% of that excess weight at 1 year. The sleeve does not require any implanted medical device. There's no plastic involved, but there are staples that are used that will stay inside, and that's normal. It does remove ghrelin and other hunger hormones, and so we are seeing improvements in things like diabetes and blood pressure, which also go along not just with weight loss, but also the change in the hunger hormones. Most patients will leave the hospital the next day after their sleeve surgery, and most patients can expect to be off work for about 2 weeks.
Well, the next procedure I'd like to talk to you about is what we consider in the United States one of our gold standard operations, and that's the Roux-en-Y gastric bypass. This procedure used to be done open, but now is done laparoscopically, just like the sleeve gastrectomy or the lap band. The gastric bypass procedure, once we're in laparoscopically, we're going to separate the stomach into two pieces using a stapling device. The very upper portion of that stapled stomach is going to be the new stomach, and we typically call that a pouch. It's about the size of a golf ball. We're then going to separate the small bowel downstream from your old stomach, and we're going to bring a piece of small intestine up to that pouch and create an anastomosis. So food will enter this pouch and then bypass the remaining stomach. This operation gets us about 60 to 75% excess weight loss at 1 year. There's no implanted device, and we've got really good long-term data on the gastric bypass. Patients after this procedure feel satisfied with how much they're able to eat, and they really feel full. The complication rate from this operation is fairly low. Most patients are usually out of the hospital within 1 day, and their return to work is in about a week to 2 weeks. The real benefit of this operation over the other two is its improvement in some of the major comorbidities such as type 2 diabetes. And this improvement happens almost immediately in most patients. So the last procedure I talked to you about is the duodenal switch. And we used to think of this operation as too aggressive. However, we're finding that for the right patient, this operation tends to be a very good operation that can give us an additional weight loss. The duodenal switch is also a laparoscopic procedure. It can be done in 1 or 2 stages. Really, it's a combination of 2 different procedures. It's a combination of a vertical sleeve gastrectomy, which we talked about earlier, where we're going to have a very narrow tube of stomach and we're going to have restriction due to the size of the stomach as well as improved satiety because of the removal of the ghrelin cells. But we're then going to disconnect the stomach and we're going to bypass a large portion of the small bowel. So in addition to a restrictive gastric procedure, we're also going to do a significant malabsorptive component where we're going to use a very small portion of the small bowel in the stream of food. So food enters into the stomach, passes into the small bowel much further downstream than normal, and we're also going to divert the bile and pancreatic enzymes further downstream. So this combination of restriction and malabsorption gives this operation significantly more weight loss than the other procedures that we've talked about. So this procedure, the laparoscopic duodenal switch, as I mentioned, first 1 or 2 stages. The excess weight loss is upwards of 80% at 1 year. Obviously there's no device, and we've got great long-term weight loss with this procedure. Complications or the disadvantages of this operation is that there is a higher complication rate because there are many more moving parts to the procedure. The vitamin deficiencies such as vitamin A, vitamin D, vitamin E, calcium, protein, and iron tend to be significant, and this procedure really shouldn't be done unless the patient understands the potential risk of these deficiencies and is committed to a long-term follow-up with the Bariatric Surgical Center. And there is a significant reoperation rate of greater than 5%. However, the benefits of this procedure are significant. There's almost a 95% remission rate with diabetes. The death rate is reduced significantly. And most patients even with difficult diabetes are off all or most of their medications. So the duodenal switch really is an aggressive weight loss procedure, but for the right patient, it can be a very good procedure that will give them lasting weight loss.
We are proud to offer adolescent bariatric surgery at the Center for Weight Management at Gwinnett Medical Center. We are a nationally accredited center accepting patients from age 15 to age 17. This is a multidisciplinary process involving both the patient, the family, bariatric surgeons, medical providers, bariatric psychologists. This is something that we're doing to aid patients who previously would be considered too young for surgery, but we're able to help them with their medical problems that go along with the obesity.
Well, I can tell you that today, bariatric surgery is an extremely safe undertaking. The mortality rate or death rate from bariatric surgery is a lot less than heart surgery, pancreatic surgery, and is equivalent to orthopedic procedures such as hip surgery. And the benefits are tremendous. We have a 62% improvement of high blood pressure, over 70% improvement in diabetes, 86% improvement in sleep apnea. And these are just the comorbidities. The first thing you can expect is that your food intake is going to change. Your lifestyles also need to change to improve success. But our goal is to improve the quality of your life, and we're looking for long-term success. The weight loss and the change in self-esteem, as you can see with some of these post-op patients, can be some of the most rewarding things that a surgeon can do. Weight loss surgery is about treating obesity. We know that obesity is a condition that will shorten your life expectancy. And what we're doing with weight loss surgery is giving patients a tool, a way of treating this disease, not for the short term, but for the long term, with the intention of increasing their life expectancy and giving them back their lives.